Hello and welcome. I'm Cheryl Parker. I am the current president of the American Nursing Informatics Association. And today I am so honored to be joined by Kathy Turner, who's Associate Vice President and Nurse Executive for Meditech, and her colleague, Janet DeRoche, who's the Associate Vice President of Professional Services. Ladies, thank you so much today for taking some time out of what I know has got to be an incredibly busy schedule to share with us what Meditech is really doing around this entire insane few months of COVID crisis.
Well, thanks so much for having us, Cheryl. It's a pleasure to join you. Boy, it has been just an overwhelming effort by both our healthcare organizations and our own organization in terms of facilitating what customers really needed in order to move this forward and take care of their patients and their staff. You know, there are a couple of fronts that really have been kind of overarching in terms of our efforts. We started in January forming an internal team, and then have met on a regular basis, keeping track of the CCD recommendations, sharing that with our customers, and I'll let Janet talk about that in a little bit. But I think overarching, the documentation of care and the virtual visits is really where we have spent the most of our time in terms of assisting our customers. The administrative burden of documentation was certainly in the wind, and customers had started working on that, but really had not put a strong effort towards that, because of the volume of information that needed to be collected in a short amount of time, and really with as minimal contact as you could. A lot of changes had to be put in place. So, just like the propelling of virtual visits, we saw that with documentation as well. So not only the standardization of documentation to make sure that we could analyze it from a organizational perspective and the patients we were caring for, but also just the ability to quickly respond to the patient's progress in care. And we saw certainly, a great emphasis on the collection of data, electronic collection of data from hemodynamic monitors and vents. The more that people were able to rely on that information, certainly reduced the documentation, made it immediately available for our surveillance tools, where we could then apply artificial intelligence to quickly warn the clinician when the patient was kind of heading in the wrong direction. So we were fortunate for those organizations that already had that in place, and we're moving that forward. And then certainly, the virtual visits have just taken off so tremendously. Customers that had that in place quickly ramped up. Those that didn't have it in place, it is amazing how quickly they learned that technology, put it in place, and switched so much of their care. And I think that's what we've, I always say, I think we have the easy part in terms of, and not that we haven't had a lot of work to do in terms of supporting our customers, but we're facilitating them. They are on that front line, having to modify, based on the CDC changes, based on the patient population that they're serving. So we're just in awe of what they've been able to accomplish in a short amount of time. We saw an increase in virtual visits of almost 600% by our customers from just March to April. And we've just got some great stories in terms of how customers have adopted that. Massachusetts has been hit incredibly hard. And Steward Health has facilities here in Massachusetts, and they were the first healthcare organization in the nation to stand up a COVID-only hospital. They had a number of hospitals in the area, so they were able to do that. Janet, you want to talk a little bit about what Citizens has been doing? Because one of the interesting things about this, both our small organizations and our large organizations have quickly adopted this capability. So it's not a matter of how big the organization is. It's really been rolled out very effectively across our customer landscape.
Yeah, Kathy, Citizens Memorial Healthcare is an interesting organization. They consist of a critical access hospital. They also have several long-term care facilities, several outpatient clinics, primary care, specialty care, as well as home health. And as Kathy mentioned, you know, the first step back in February, beginning of February, was to disperse some algorithms that could be used by our organization to screen for patients under investigation for, at the time it was coronavirus, now it's COVID-19. So that was really the first step. And what was interesting is that we had to track both the CDC and the WHO because we have international clients throughout Canada, the UK, South Africa, but also the US. So that was really the first step, is to make sure that what we deployed as far as not only guidance, but built-in clinical decision support had the input from the clinicians, the nurses, with regard to workflow. And the goal was, if you could, to avoid having those patients come to the hospital in the first place. So that really consisted of not only virtual visits, which we will talk about in some detail, but also remote screening. So really using virtual care in a ramped up way to protect patients and to protect the providers within the hospital. So Citizens Memorial, they have really taken virtual care, which I'll call it, and they've implemented in terms of remote screening, and there's been good adoption. Even though there's some, you know, literacy issues in the field, patients have adapted well. And a couple of anecdotes. One of the things that they found were patients were getting anxious and they were calling to cancel appointments. And during that conversation, they would offer them a virtual visit, and many patients took advantage of that. As we know, not only are we at risk with the COVID-19 patients, but often patients have been delaying care or not going for care, chronic disease management and such. And Citizens has been able to use virtual care for both COVID-19 as well as to continue to care for their patient population. I know they've also used it in the long-term care facilities, very vulnerable populations, as we know, in that particular demographic and age range. So they're doing virtual consults. They're also using virtual care to communicate with the patients and the patients' families, which is so important in that environment. And then lastly, they've been very progressive with mental health care. So in these times with social distancing and stay-at-home restrictions, we know that people are struggling with addiction and other types of mental health conditions. And Citizens has done a really remarkable job mobilizing virtual care for mental health.
Right, and they really have run the gamut of offering this in both the acute care setting, the ambulatory care setting, as well as mental health. And we've been fortunate that we had virtual visits embedded in all of those environments, as well as home care. And it's interesting in home care, as the restrictions have progressed, the clinicians were first going into the home and being very cautious. And then they started having to wear masks. And then they started having to wear masks with a shield. And the impact on patients, that the older population that is perhaps hard of hearing, now all of a sudden the mask is impeding that. So those areas that had adopted, mobile devices, that's really helped in those situations where the patients could actually see the screens and could understand what the clinician was talking about and what those next steps are, because they lost that ability, those facial keys and some of the lip reading to be able to better understand. So, our customers have just done a tremendous job of really meeting the needs of the patients wherever they are and trying to keep them out of the acute care setting. I was on a call earlier today, and every organization has stories about having to set up ICUs. One of the sites, Butler Health, where we're doing an implementation right now, their biggest training room is now at the ready for overflow ICU. They haven't had to use it yet, but it's all about being prepared. Another organization just set up a unit in a local hotel because they had no more bed space in their organization. So As I said, we really are in awe of what our customers have accomplished and the challenges that they have been under. Certainly, they've had to bring additional staff on during this time. They've had to ramp staff up very quickly, not only from a care delivery model, they're bringing in nurses that might not have worked in the ICU for some amount of time. So there's the training of the care delivery, but there's also training on the EHR if they haven't used that before. And because we were able to quickly adapt to virtual trainings, we've been able to assist in that manner. We've been able to provide some micro learnings for our customers to quickly bring those organizations up to speed in that manner. But just virtual visits in and of itself, so many organizations, it was new for them and they had to quickly bring that up. And, we had customers routinely doing that within 2 to 5 days, bringing up virtual visits, having never used them before. So as I said, just a yeoman's effort out there in terms of what they have adopted in a short period of time. And, at the basis of all of that, Janet, you and I talked about this a little bit earlier in terms of the value of that data that is being collected. And as I said, not only analyzing it from the patients that you're serving and the organizations, but also what else we're doing with that data and where some of that is being submitted. Janet, I don't know if you want to talk a little bit about some of the efforts in that area.
Sure. And I know it's important from a nurse documentation standpoint that we try to be as efficient relative to reducing the amount of documentation. But the other thing that has been really critical is that we have the data that we need to make decisions. So there are obviously reporting requirements to the public health departments, to the county, to the state, to the CDC, FEMA, and we need to have mechanisms in place so that the data is being collected, because a lot of that data is being used to allocate supplies to manage where ventilators need to be sent next. So there's that reporting requirement. And then also as critical is within the organization, not only to screen the patient and understand whether that patient is under investigation or if they're COVID-19 positive or negative. If they're negative, that means I can use the PPE elsewhere, but also at the point that I'm trying to look at that patient from a clinical and a predictive perspective. So using scores like the SOFA score and the modified SOFA score and other scores that are used to assess patients that may be eligible for ECMO, being able to build those into the system. And from an informatician standpoint, the reliance on codification in the background. So there's the workflow piece, there's the public reporting piece, and there's the clinical decision support piece. And that requires in the background that things are codified. So as many of us know, there's a number of things that change relative to ICD-10 codes, relative to LOINC codes, SNOMED codes, CPT codes. So at the same time, we're trying to support the nurses and the doctors in the field taking care of these patients. We're also trying to make sure that the informaticians, the background, have the codes they need so that we can provide the support that's required.
Right, and the other piece of that, Janet, is the asset tracking as well, which we haven't talked a lot about, except for the PPEs. But knowing where those beds are, what is available, where you're able to move patients, and where are the vents, so that when you do have to set up a new unit or where you have overflow that you need to take care of. So all of that is so dependent on the data. And, I think our organizations that have always done a good job of standardization, this was a little bit easier for them, but they still had additional data fields to add. Some of the data sets that had to be submitted to those reporting agencies that Janet mentioned was so critical in terms of making sure that data was collected and putting those guardrails in the system to make sure that somebody didn't miss those as they were evaluating the patient or collecting the data. I'm sorry, go ahead, Cheryl.
No, go ahead, Kathy.
I was going to say, just a thought to go back to the training. We've all learned from each other during this period of time. And one of the things that we are fortunate with our Meditech customer community is they are very generous with each other, very willing to share what they've done, what has worked well. And we were about to have our annual user meeting coming up. So that quickly transitioned, and that will now be fully transitioned into a virtual meeting. But that group took advantage of the opportunity to really turn that into virtual meetings, where we've had customers speak. We have presented as well in terms of what we have done and what customers can take advantage of, or what we're able to deliver to them. So the reliance on each other during this time has been paramount as people work through this process and define what the right path is for each organization, and really, share those things that were unique to them and others are able to take advantage of.
Yeah, that's kind of how this whole interview series got started.
Yeah.
Was from one of our former president of ANIA, who was like, I'm getting so many calls from people wanting to know what we're doing here at Vanderbilt. Is there any way we could just record this and I could just send them to and that's kind of how this whole thing got started.
Right.
And it's only been like 2.5 weeks. And I think you're number 10 or 11. I've lost track. I'm doing so many of them. It's just, but it's that everybody has been willing to share information, learning. And one of the things I want to ask you guys is, now they're talking potentially that this will be coming back in waves. We may see spikes again. What are some of the things y'all are thinking about, or lessons learned that we need to think about going forward?
Well, certainly, the progression of this was very interesting. And as the situation became more critical and more global, certainly our tact changed. And we realized that this can't just be an effort that comes and goes with the latest disaster. And I think on one of your interviews, actually, you talked about the fact that you think of disasters in terms of very short periods of time, and this will go on for months now. So how do you sustain that? And so not only do those organizations that have prepped in anticipation of, now have gone through that process and know what they can quickly put in place if that surge does hit them. And same internally with our organization, we have this structure in place so that as any of the guidelines change, we're able to quickly react and help our customers. But it is something that will be forever in place. You have to be ready. You don't know what's going to change. You have to be able to react quickly. And I think, we've all had that structure in place, but the critical nature of this that advanced so quickly certainly made us all glad that we had that in place and could move, on short notice to provide our customers what they needed.
I was thinking back to how many years has it been now since we had Ebola and that first patient? And everybody was like thinking about it, and then it kind of went away. It kind of went out of our consciousness because it really didn't evolve to what it could have been.
Right. And I think people quickly went back to that example when we started and focused first on where patients had been. What was their travel like? And it just quickly changed. The impact of this being global quickly appeared, and it became about what are the symptoms, and then worry about contact tracing after, because it just accelerates so rapidly in certain individuals that that became the focus as opposed to the location. And now certainly the contact tracing is going to be very important as organizations decide how to get back to normal. And I think just the history of these sessions that you've had Cheryl, at the very beginning, nobody was talking about, well, how do we open back up? And now we have organizations that are looking at, restarting some of their elective surgeries.
Yep.
So it has certainly been an interesting progression. I think we're all better prepared for the future because of it. And frankly, have done some things that we should have done all along. The
Yes.
standardization, the virtual visits, certainly the regulations changing around that gave people the impetus to adopt that. Some of the geographic restrictions, some of the, the financial impact, easing of that really allowed organizations to say, yes, we can do this. And they did it in such a short amount of time that it does, it makes me hopeful for them continuing to adopt technology when it's available, as opposed to putting it on the back burner for when they need it.
Yeah, because we really have to admit now we are a global society.
Yeah.
And this is probably not the last time this is going to happen.
Right.
I mean, even this novel virus now, but 2 years from now, 3 years from now, what's the next one that's going to come? Because it probably will now.
Right.
And yeah, looking at the maps where it came in from different areas, the East Coast more got hit by Europe, the West Coast got more hit by people coming in from the eastern part of the world.
Right.
That kind of stuff is almost irrelevant anymore. It's, what do you have?
Right. And certainly, we hope that some of the, you always try to look for what is going to be positive as a byproduct of this. And you hope that, telehealth will be more of a mainstay. Janet and I were talking a little bit about the public health reporting earlier, and the fact that needs to be a bigger priority. Janet, I don't know if you want to speak a little bit more to that.
Yeah, and it would be interesting to hear, actually, I would be interested in your perspective, Cheryl. The role of public health has just been so elevated in this crisis. And public health has not had the technology or the ability to share data like what promoting interoperability did to other providers. So I think the role of public health is going to be at the forefront here and something that we need to pay attention to. I'm curious what your perspective is on that, Cheryl.
Absolutely. I mean, one of the things, again, if you're going to look for some silver linings, some of the silver linings we've got to this entire situation is, what did it spotlight as areas that we have got to improve on? And we now can much better explain why we need to improve on them, because you're right, public health was kind of over here, and it was kind of about immunizations, and it was kind of about this, and it wasn't really okay, yippee. But suddenly it's like, oh my gosh, we've got to be able to do the contact tracing. What with pieces of paper? I don't think so. And I've been around long enough, 43 years of nursing, to remember when everything was paper. And I just, in my weird dark moments, think about what this would have been like in a purely paper world. It's like a nightmare.
It's a good point.
Well, funny anecdote about being on paper. One of our organizations quickly set up a clinic that had been on paper before. And because they were trying to reduce the paper and the handing off, they were forced to do CPOE on short notice, and they did. Which just goes to show we can all adopt these technologies, and we need to make them a priority. But back to the public health, I just, all the immunization reporting, we were mandated to do that, so I certainly hope that now the reporting that is being required is a mainstay, and that everybody sees the value, and it will be hard to not see the value after this. And, you just look at what the states are reporting, and you look at each state map in terms of the number of cases, and you just recognize the importance of all of that. I know in Massachusetts, 97% of the deaths actually are related to the comorbid conditions. So it just so shows that value of data, and that we have to rely on that, and we have to, if the states can do that and report on it, certainly we need to do that nationally and internationally as well.
Absolutely. It's really shown a light on what we as informatics nurses do. What is our value? Gee, let's think about it. And I really think it's going to push the future of data analytics, the dashboards, the real-time information, trending analysis, etc., that needs to get pushed out into public health.
Absolutely.
That we haven't really put eyes on yet. So I think this is also going to change our healthcare environment in ways we haven't really totally appreciated yet.
Absolutely.
So yeah, it's going to be an interesting next few years.
It will, and I think the larger organizations were certainly doing a lot of this already. I think the smaller organizations didn't know they could do it, and they've kind of proven to themselves that they can.
Yeah, that whole thing about when you got to do it, you just do it. I'm sorry, you have no choice. There's no excuses. There's nobody to take this to. Do it.
Right.
And it's like, oh, okay, I guess we can do it.
Right.
So, I don't want to take up too much of your time because I know how busy you are. Is there anything else that's really you're burning to share with the world out, or at least the listeners of these?
I just want to close with, something that you kind of left off in your last statement there. We have a nursing forum every year, and, it's all nursing informaticists that attend primarily. And I always close that meeting with reminding the nurse informaticists to never underestimate the impact they make every day. They're behind the scenes, but what they do impacts every clinician and every patient.
Yep.
And, they're not on the front line, so that's not often seen. And, certainly our hearts pour out to those that have faced challenges, and we couldn't be more grateful and proud of those that are on the front lines, but we're as proud of those that are behind the scenes.
Absolutely. Janet, anything you'd like to close with today?
I don't know that I could articulate as well as Kathy does, but I will say from an informatics perspective, we're inspired daily by the nurses that we see working in the field, the quality nurses, the respiratory therapists, the physicians. They move us and motivate us to continue to use data to make their jobs better and easier.
Yeah, data is going to be the thing that's really going to be transformed in the use of it. So
thank you, Cheryl.
I truly appreciate y'all ladies. Thank you for spending some time with us today. And hopefully we'll do this again one of these days.
Thank you.
All right, it would be our pleasure. Thank you so much,
Take care.
Cheryl.
Bye-bye.